the title, the emphasis that I am going to use for the afternoon talk on transference is really on the general subject of transference rather than perhaps what the title of the conference as printed suggests, which is in children and adolescents. I might refer to that at the end, but it seems to me that perhaps it's better to deal with the topic in general. Now, if you talk about transference, obviously you have to talk about it. It's a theme that is so closely linked with other themes that if you talk about it, you have no alternative than to talk about these other themes a little bit that are related to it. And so if you talk about transference, you have to talk about countertransference too. No way you can avoid it, yes. And if you talk about transference, you have to talk a little bit about acting out, because there is some kind of relationship, particularly perhaps in the historical sense, but not only, between these two concepts. And because the concepts, as they develop through the years, and this, as you are aware of, is a very old concept. It's about 80 years old now. And of course it was a concept that, like all the others that I just referred to now, transference, countertransference, and acting out, were all developed by Freud at different points in the development of the psychoanalytic model. This particular one, as I said, and let me start where a resident of psychiatry of the department yesterday forced me to start a mini discussion that sort of let me train a little bit for today's chat. He asked if it has started with the patient of Freud a long while back, and that the concept came out of there and some difficulties that were in that particular area, and of course he was right. He was referring to the Dora case. And it was the Dora case, and what happened with the Dora case that brought sort of to Freud's mind in a very dramatic fashion, only that a posteriori, yes, what had happened with the case, and out of that awareness developed the concept of transference. Essentially what happened was this. The Dora case was a very interesting case, which I'm sure many of you have read, that didn't end too well because Dora got sort of very angry with Freud and stopped the treatment in a rather dramatic fashion, in a fit of anger, essentially, and dissatisfaction with him. And looking back and thinking back as to what it was that had happened, and of course Freud had had some inkling of this before because he used to collaborate with another physician in Vienna that was in fact in a way his protector, a man by the name of Breuer. And this man had some experience with transference in rather dramatic situations as well. In other words, patients that he had treated had become so fond of him that made some kind of open overtures to him that were clearly of a sexual matter, and this highly sophisticated Viennese physician, a great Victorian, got quite traumatized by the behavior of this rather young and attractive girl and got quite frightened by it. But being a man of a great character in his own way, he discussed it with a much younger colleague and friend, in fact, somebody that he was very fond of, and that was Freud. And Freud gave a lot of thought to Freud. Yes? And of course, out of that collaboration, as you know, came the studies in hysteria, where they are essentially the two first theories. One is one of the existence of psychological conflict to explain symptom formation in neurotic conflicts, and the theory of Freud, of Breuer, which is essentially a theory where there is a dissociation of affects from ideas and a sort of damming up of the libido and then outbursts of abreaction totally dissociated from its ideational content, and consequently they never come to an end. The idea and the affect have to come together in one form or another, and that was the beginning of everything. Freud, looking back at Dora, came to the conclusion, looking at the history, that what has happened was very simple. Dora, as a young girl, or rather already as a young adolescent, had developed a lot of fantasies about a very friendly neighbor that she had that was a married neighbor by the name of Head K. Head K was a very charming man, and obviously Dora was a very charming girl, and he behaved in a rather seductive manner towards her. But all within the, confines of propriety. There was nothing inappropriate about it. But Dora, being young, being an adolescent, and being full of fantasies, developed all kind of ideas about her case interest, which of course ended by being disappointed because she never did anything with Dora in the sexual sense, and her sexual fantasies proved to be just that as far as she was concerned, sexual fantasies. Now, when Freud treated her, what happened essentially is that she displays to Freud the feelings that she had for her K, which were already, of course, a second edition of feelings. Yes, these were feelings that obviously were a re-edition of her own Oedipal feelings in the form of it being related to her K, and so the whole situation developed. And being disappointed that Freud did nothing either about her sexual longings for him, she got, like any lover, quite disappointed and enraged, and essentially interrupted in a rather dramatic manner the relationship. And Freud realized that the treatment came to an end because indeed Dora gave to him what she had intended to give to her K had she been able to do so, and that was a little hell for having disappointed her. So, and that's where the concept of transference developed. You see, it developed in a rather dramatic form. In other words, it ended the treatment rather badly and rendered Freud totally helpless in a way, you know. It simply happened, and that was it. That was the end of it. He looked back, he understood what had happened. And so he made a statement, which is true today, but has been very much misunderstood. He said, transference is a resistance, and it's a bad form of resistance. It can end with the treatment. Can bring a treatment to its end, yes? And of course, that's certainly true, and it still happens very frequently. At the same time, there is another statement going around about transference, and we should define it in a moment, because we are talking in the abstract at the moment. But there is another statement that goes in the direction that transference is the best possible and most valuable tool that a psychotherapist has during the course of treatment. It's one of the most valuable tools in his armamentarium. So you have these two sort of statement concepts that belong in a continuum, like two extremes of a continuum. It's an absolute resistance, can end, bring things to an absolute disaster. Is the best thing that can ever happen in psychotherapy, the best tool if you utilize it appropriately. And some people get quite confused. How can you be black and white at the same time? Well, you can. And not simultaneously, but in sequence. And we will discuss that a little bit. In any case, what transference means is the displacement of a variety of feelings, longings, wishes, needs, fantasies, and so on, coming from the long past, as from childhood, and that were feelings that usually corresponded to whoever were the primary objects of this particular person, and these are displaced to a person in the here and now. And that person, of course, if we are talking of psychotherapy, is the psychotherapist itself, but it needn't be the psychotherapist. Transference is a universal phenomenon. It doesn't only occur within the psychotherapeutic relationship. It constantly takes place when two human beings relate to one another. So it's not the exclusive property of psychotherapy, though indeed psychotherapy may do certain things that promote the development of transference in one way or another, and we will discuss that a little bit too. The other important element of that definition of transference is this. The patient is never conscious of what is happening. It just happens. In other words, he is not aware that he is displacing these feelings from the past and that used to belong to his relationship to father and mother and son, the primary family, so to say, to this particular person in the present. He has no awareness of that. In fact, when he is under the impact of these feelings, he feels these things as in the here and now feeling absolutely real and related to this particular person, and this particular person behaviors towards him or towards her. So that, simply put, is possibly an acceptable definition of transference. Now, there are many types of transference, as you will imagine, yes? There are transferences that are called father transferences, mother transferences, sibling transferences, brother transferences, sister transferences, all kinds of transferences there are. And they usually come in the treatment in a sequence. And the order of that sequence depends on the developmental history of individuals and the life vicissitudes of these individuals. But it is it is likely to happen that in the course of any treatment that will last any amount of time, any one of all of these forms of transference will make its appearance at different times. And they will go away and come back, and you'll be father today and mother tomorrow, and naughty sibling the day after, and whatever. And so it goes. That's the nature of the treatment. There are other things about transference that are important. There is this statement of transference as a resistance. And then, of course, Freud started to become very interested in this phenomena and to devote a great deal of attention to it. And this was 80 years ago. And he, after he made this discovery, he lived for many years and treated many patients and did many observations. So he had a great opportunity to develop this concept very, very extensively, yes. And then he came to the conclusion that there were several other forms of describing the transference. In fact, that transference is a very complex phenomenon. And some of the so-called transference could be described as positive transferences. And there are other groups of similar phenomena that could be described as negative transferences. And that both of them come into the treatment situation, and that some patients will, of preference, use the one to the other or use one against the other, just as sometimes heterosexual behavior is used to cover homosexuality. The same is true in terms of transference. Some people will produce only negative transference in order to defend themselves against the strong positive longings that they have for the person of the therapist. And this being quite conflictual to them and unacceptable to them, and the feeling sometimes that it puts them in a too regressed and too dependent position, they will fight it with all they have, and that's a lot of hostility and hate and resentment and so on. And the opposite is true. Some people patients may well hide their negative feelings to the therapist by covering it under a chocolate coat of love. But there is cyanide underneath the coat. And that's true of all human relationships. But of course, as we will see in a moment, there are special reasons why that is more so in a psychotherapeutic relationship. Now, looking further, he came to the conclusion that there were several types of positive transference, and that was very interesting to him. And he described roughly, and to be schematic, two types. And the first type within the positive one was what he called, there is a group of displaced feelings of the patients from the primary objects into the person of the therapist that you could describe as being related to the current of affectionate feelings that a child feels for his parents. And he means affectionate, non-erotic feelings, but just that current of affection that is not enormously sexualized, just an affectionate feeling. And that, of course, is a form of friendly or very positive sort of element in the therapeutic alliance, in the therapeutic relationship. And there is a second positive type of transference which is a little more troublesome than this first affectionate one, and that's the erotic transference. When that transference becomes a love feeling, an erotic transference, and of course this love feeling can come in little small bottles or big ones, yes? And of course the intensity, the quality, the quantity, the type of personality of the patient will determine what the fate will be of that new development. So in terms of the positive transference, you can think of two types, the friendly one and the erotic type, the sexualized type, the non-sexualized and the sexualized one. And then there is a negative transference, and of course if that is all the patient has a capacity for, the possibilities of establishing a psychotherapeutic relationship are very, very limited indeed, you know. You need something more than that. There is very little, and he said so, that there was little possibility of influencing or curing anybody whose negative was essentially, whose transference was essentially of a negative nature, and one could not get hold of the other aspects of the transference in due time. Now, it doesn't mean to say that the negative transference is not an important part of the treatment that will contribute very significantly. Indeed, it is. A lot of people, given the nature of their object relationships and their own needs and the way they perceive events early on in life, are full of hostility and hate toward the primary object. Whether that is justified in reality or not is irrelevant, but they are that way, and obviously that transference is going to be very stormy and essentially characterized by these negative aspects to it. And they are very trying cases, as you will imagine, yes? Because they give it to you in all forms every day for many years, yes? And that's not easy to put up with. So there is... then he came back to the idea of resistance as related to the transference. When is the transference a resistance? When it is not a resistance, but an assistant to the treatment process. And he came to the conclusion that two of these different forms of transference, the negative transference and the erotic transference, are the greatest potential for resistance in a psychotherapeutic relationship. They need not be, but they have that potential. Okay? They can be very useful if contained within certain limits and handled within certain limits. If they get off hand, they are trouble, and I mean big trouble. Big trouble. The positive, friendly, affectionate one, on the contrary, is working for the treatment and makes the patient try to, as you do with when you like somebody and feel positive towards and you want to please them. And if you remember that these are transference from a long past back, which means it's a relationship of a small child or a small little boy or little girl to her parents. They want to please like nothing that you have seen, and they bring this wish to please. And so they are willing to do all kinds of things for you on the basis of this transference of positive, affectionate feelings. And all you are asking is, look, be honest, associate freely, face yourself. There are difficult things, painful things to see and look at and so on, and they will do it because they want to please you. They like you. You are so wonderful, yes? Now, obviously, you don't want, you will use that. There is nothing wrong with that. That'd be very useful. And you don't interfere with that too much if you don't need to, as long as it is working in the right direction. Obviously, at some point you will have to take hold of that and make it a part of the analysis. You analyze the positive, non-affectionate, non-erotic transference as well. Because by the same token, you see, this person may well repeat this behavior with every human object that they relate to and be quite inappropriate because he's compelled to please objects even when that shouldn't be the case at all, and it wouldn't be in the best interest to do so. And consequently, any self-respecting therapist knows that though he's using temporarily these affectionate positive feelings because they are working towards the aims of the treatment, at some point they will have to be looked at. And so to say, using a term that is descriptive and in that sense useful but really very poor, resolve it. Whatever we mean by resolve it. Yes? Now, obviously, the concept of ambivalence is related to this. In other words, whoever we value as an object or relate to as an object, we both love and hate. We have both positive and negative feelings. And, of course, these are generally directed simultaneously towards the same person, and it is quite shocking that we can love and hate the same object, but we do. Now, usually we don't do it at the same time, but we do it in we sort of make a sequential order of this. So we have this need, as I said, of looking at the transference, including the positive one at some point, and trying to understand it and resolve it. Though for a while we may let it run if it is working in the right direction. And that's easy to do because it's working for the aim of treatment. With the negative transference or the erotic transference, you have to be a little more active than this. You can let it run indefinitely. You have to get into it real quickly because it has that enormous potential to create big trouble. And once it grows far too big, it may be impossible to handle. It may be too late. That's what happened in the Dora case. Yes, it grew too far without being recognized in time. Now, that's a transference in general. There is another concept which is very, very misunderstood and very related to this, and people sometimes treat them as synonymously, but they are not. And that's the concept of the transference neurosis. See, transference and transference neurosis are not one and the same thing. So frequently when we talk to one another, we use it as equivalents or synonyms. They are not. The transference neurosis is another observation, a very interesting one that Freud made while he was looking at the transference phenomena. And it is this. You see, the patient usually comes to you with whatever number of complaints he has about his condition or his suffering or his phobias or his compulsions or his impotency or whatever the symptoms are. He comes, gives you a list and says, look, this makes me suffer a great deal. I want help with this. I'm not functioning properly in this area, that or the, whatever it is. Yes, and these are his symptoms. And you, on that basis, with the patient, made the decision that, yes, indeed, you think that these treatments might be the right indication for dealing with this particular problem and so on, and so you make a combined decision and start a treatment. Only that sooner or later, you may find with some patients, and this is becoming more and more rare nowadays, and we can discuss that later a little bit, but this was quite common some 25, 30 years ago. Yes? Not so common today. What you will find is that all of these symptoms at some point started to get sort of obscure, as if suddenly a fog came over them and they were difficult to see. The patient didn't talk too much about this. He was now concerning himself or herself mostly with what was happening in his view in the relationship between him and this person that he had gone to see. And that became so important that the patient no longer complained about the phobias, but complained about the fact that you don't seem to be too happy to see them today. You look solemn. Or maybe that you can put up with them, and that's why you have such a long face, Or maybe that's why you came 15 seconds late out of your office and didn't pick them up in time, or whatever. Or that's why you are taking this time 2 weeks vacation instead of the usual 12 days or whatever. And so it goes. What is of significance is that the complaints that brought the patient to the treatment tend to disappear, and enlarged, new, totally original, created in that new setting, in that new relationship between these two human beings, takes the place of the original neurosis. And it's a new neurosis. It's one that takes place within the four walls of the psychotherapy setting and in this relationship. Obviously, you realize that behind the theory of object relationship, as we understand it today, is the theory of the concept of transference. Yes? It's how we relate, what these expectations are. Well, that new neurosis is what is called the transference neurosis. The transference neurosis is a new neurosis. It's a terrific thing to happen. It brings a conviction into the treatment. You see, it's like a lab situation. It's really a strictly well-controlled, like a biological experiment. And it has all of its rigor, too, if you think about it in this sense. You see, when the patient tells you that, what I was saying yesterday in another group, that his father never cared for him, he was too busy with his profession or whatever, that may be true. Maybe it was not true. Maybe he was too busy with his profession, but that doesn't mean to say that the father didn't care at the same time for his child, though that may well have been the way he perceived it, yes. How it was, as I said yesterday, it doesn't really matter all that much, because that's his psychic reality, and that's what you are concerned with. But you were not there, and you certainly have no means of saying that is really an objective statement or it ain't. This is just a result of this patient fantasy, and the way he perceived this on the basis of who he was and what his basic needs were like, and so on, how he interpreted events. Yes, it really doesn't matter, as I say. What is important is the psychic reality, though it has some importance, as I will try to highlight for you in a little while. In any case, in this lab situation, you certainly know if your face was long or you came out 15 seconds late because you didn't want to see this patient, or you don't like him, or you don't like the size of his nose or the color of his shirt, or, whatever. You know that. And you can hear what he says. You see, he's describing to you your feelings. And at least you should know what your feelings are. Or at least to some degree you will know what they are. Though you have to treat that with some with a pinch of salt, because we don't necessarily know all of our feelings all of the time, yes, and we do deny things and distort things and things of that kind. But on the whole, you see, if you are in this field, you are trained to pay attention to yourself, you are trained to pay attention to these feelings, especially the feelings that are provoking you. Indeed, you were willing to take a good measure of the or a good measure in the sense of a good doses of the same medicine that you have prescribed for other people. So you have some personal experience of what it is that is happening and how many of these things may have an impact on you, hopefully, yes, if things have gone well. Which means, in a way, you have controlled most of the variables in that situation, and there is a new one that the patient produces for you and lets you see how it develops gradually and little bit by little bit. And he has this element today and this other one tomorrow, and all of it is contained in what he feels you feel for him, and you do with him, and why you do or don't do, and what you are willing to do and not to do, and why, and who you prefer, and you like women patients better. You get very happy when you get out of the office when this attractive woman leaves, but when he leaves, your face is not that happy. So that means to him that, of course, you are very interested in this lady, but not in him. Or the other way around, you know. God knows what he will create. It's a very creative situation. So that new transference, you see, is much more easier to tell in good time, to get hold of some of these feelings of your patient that have developed in that context, and to be able to demonstrate to him where these feelings come from and how little actual reality there might be for the strong reactions that he's producing and the incredible inference that he sometimes draws from it. And that has an incredible conviction. The patient will say, you know, you are right. I don't know where this anger can come from. Certainly these 15 seconds that you were late wouldn't justify it at all. Sometimes you are 1 minute early. I don't think you watch that closely. And he starts to ponder. You see, give you an opportunity to see the animal develop in front of your eyes and to get to know him real well. And consequently, with an enormous conviction for yourself and for your patient, to start to handle those conflicts that he's now displacing towards you and towards this new relationship that are responsible for this enormous reaction that he's producing in this new situation. Yes? And that's the transference neurosis. Very, very important. So, once this happens, this is possibly the best form of transference to develop, certainly in a long-term or psychoanalytic type of treatment. It's a rare phenomenon nowadays. It used to be very common when we had the good, reasonably healthy, neurotic people looking for treatment. It is something that doesn't tend to happen with borderline and narcissistic and impulsive character and, addictive characters and things of that kind. So you don't see as many of these as you used to see in the past, which is a great pity, and in a way perhaps explain why the prognosis of many of these things is much more severe. You don't have these terrific opportunities of this strange but extraordinary development allow you to do therapeutically with these patients. Yeah? Now, the transference is a very powerful instrument. I have developed an interest in computers of late. And one thing that it's a term that is very attractive. They tell you that's a very powerful program. The moment you hear it's a powerful program, you know it's something really good. You want to know what it is. Well, the transference is a very powerful program, an incredibly powerful program. It can do all kinds of things in all kinds of situations, not only within the therapeutic treatment situation itself, anywhere else. You see, you can transfer anywhere. You can transfer to your boss at work and have expectations for him that are quite inappropriate, or maybe provoke him quite inappropriately, yes? Or long for his approval and so on in ways that he couldn't possibly dream that you have these problems, or will he understand it, and certainly will be quite irritated by it, because he's not your father, he's not there to pat you on the back, he's not trying to get you good, he's not trying to disapprove of you, he's trying to do his job. He's trying to be your boss, he's trying to earn his salary. You transfer there, you can do all kind of things and misinterpret the behavior of this person exactly as you misinterpret the behavior of the therapist. Usually, of course, the vicissitude of that is very different. You see, the therapist sits there and lets you develop your fantasy. He doesn't say anything. He lets you talk. And in not saying things, that in a certain way tends to develop the transference even further. It's like an encouragement, you know. So when you approach a girl and say, you know, you look pretty, and you hold her hand, and she doesn't say, well, look, don't bother me too much, you know. Don't take my hand. I mean, you say, I'm doing well. I mean, there is hope, okay? So it escalates a little bit. Not doing anything, just listening, in a way, seems to have that effect on some patients. It's like they seem to be thinking that they are going in the right direction. And since they are the owner of their own fantasies, they can develop them in any way they want. And obviously, that's exactly what you want to happen, within limits. And you will know where to contain it, how to contain it, and where to intervene. You don't want these things to get off hand at any given point, but you want them to develop because they will show you what your patient's problems are like, where they started, what characteristics they have, what they mean to him, how they interfere with him, how they distort reality for them, how they interfere with his functioning. And obviously that's what you want to know so that you can help them in that particular way, yes? So it's an extraordinarily powerful situation. On the other hand, you see, your boss is not going to do that. If you don't behave appropriately, they are reactive to your inappropriate behavior, and that will set immediate limits. In other words, there is an enormous amount of reality testing in ordinary object relationships, which there is not of necessity to the same degree when you are dealing with your own therapist in a psychotherapeutic situation. Yes, you are as interested in the fantasy elements of the relationship and the past transfer elements of the relationship, in fact, more so, that in the real relationship. Not that you ignore the real relationship, that is very important just as well, and you will use just as well, but you have two set of elements. Your boss is not interested in your transference. He's interested in the real relationship and will react accordingly, yes? Now, obviously, there are other things, yes? If you make a patient lie in a couch, that's conducive to certain regressive things and associations, certain memories, the reactivation, the reenactment of certain feelings becomes a little easier, and so on. There are a variety of things that go in that direction, yes, and make the difference between the qualitative aspects of a transference development inside a psychotherapeutic situation and outside one. Now, being as powerful as it is, the transference is so incredibly miraculous that it can produce a cure from this minute to the next one. And these are called transference cures. You don't like to see them. They are no good. But they are really fantastic, you know. It's like if you have the gift of making people well by just addressing them or touching them or looking at them or whatnot, you know. Now, Freud became aware of this, and indeed there were many patients that will lose all of their symptoms rather quickly, and without there being anything to be shown in terms of the work that you did, so that these symptoms will disappear. In fact, they disappear simply because the patient loves you, you know, and does it to please the therapist. And so he's well now. Obviously, it's an incredible resistance. Don't be misled by it. Essentially, that patient talked himself out of the psychotherapeutic situation and looked at himself by making himself good. He may well be doing that partly to please you, yes? And obviously, that will only last for as long as a strong positive relationship to the therapist is valid, and that's not going to last very long, yes? To start with, I mean, patients don't retain the therapist for life, you know, in a retainer. So sooner or later they go their way and the therapist go their way. At the moment that positive, affectionate current is not there, the patient is back in a square one with all of his symptoms and perhaps a few more, yes? And a disappointment on top of it. Now there is obviously the common phenomena is the coexistence of negative and positive transference. That will be the norm, yes, with most patients. Though in any given patient, and for very specific reasons belonging to that particular person, you may find that they combine the positive and the negative aspects of it in different proportions, and this is very variable from one person to another and be very meaningful in terms of what the proportions are and in which sequence they appear and how they manifest themselves. I mentioned to you already that for that very reason, the one type can be used to hide the other type. In other words, you can only profess the love to your therapist to hide your negative hostile feeling towards him and the other way around, yes? Now, the specific characteristics of the transference obviously will depend on the patient neurosis and his developmental history and a number of other factors. Notice what we said a moment ago, the transference neurosis. It's a special form of transference in a special form of psychopathology, special form of problem. There are other type of transference that people have described things. And some of them are very popular nowadays and heard a great deal. There are transference that are produced by borderline patients, and so they are called borderline transferences, or psychotic transference, or narcissistic transference, and so on. And they are related to this phenomena. Indeed, sometimes they may be, very, very closely related to one another, but they are not one and the same thing at all. And there is some danger in calling some of these phenomena at times transference, because they may be something quite different, and I hope to get to that at some point. There is another very interesting phenomena which I referred to already, and that is the phenomena of the transference love. And that may be, of course, the way it was described originally, and here you see what the influence is in the development of concept of his own history. See, in those days, a large majority of therapists were males, and it was very likely that the large majority of patients were females. That's not necessarily true today at all, yes? But it got then to the description of transference laws, mostly in terms of a female patient and a male therapist. Nowadays, of course, all he has is the slightest doubt that the same applies to a female therapist and male patients, and that exactly the same situation exists in that particular case. Now, obviously, you expect the development of love in the transference. We love both parents. And so that means that we will manifest in the transference both our heterosexual love and our homosexual love, and that there will be conflict between these two. And that the nature of that conflict may be very relevant to a particular patient, not necessarily to all patients. Some patients, this may be the main area of conflict, for example. To some other patients, this may be a sideline to the main area of conflict, and so on. Whatever it is, there it is. It's going to develop. And if it is within certain limits, it's a terrific instrument. It's, that you welcome it, you want it to develop, you want to be able to use it, to analyze it, and to try and resolve it in inverted commas. The love transference is the transference which becomes a transference love can become a problem, and a bad problem, serious problem, in many ways. I need not tell you that one of the unfortunate situations in the field of psychotherapy today is that people lose control of their affects. And by people, I mean now therapists and patients. And I mostly place the responsibility for it in the therapist, because the patient cannot do anything else but transfer to you the love, yes? And you know that one contemplates with horror the fact that there is a lot of acting out in psychotherapeutic relationships that end in bad relationships between patients and therapists, which is the most unfortunate development. But it does mean that therapists are human beings and subjected to their own personal conflicts and needs and narcissistic pressures, and it does mean that it is undoubtedly somewhat pleasant to everybody, even the most rational and well-measured therapists, to hear people say how attractive he is and how handsome he looks, and whatever is the fantasies that the patient develop, yes? And some people seem to get carried away and really make something out of it, and that ends in an absolute disaster. You don't want that, obviously, to happen, yes? You want to use this in a very constructive and positive manner. Now, if the love, though, grows off hand, particularly grows off hand, grows too large, too difficult, it becomes too big an animal, it may become impossible to resolve by a particular therapist. And this is true of certain patients. Freud has referred to them in what some people will consider to be some pejorative terms, that there was nothing further from him than being pejorative about any of this. But these are patients that are somewhat primitive and infantile, and once they develop a need, they must have it gratified. They cannot deal with that need by other means, by the immediate gratification of it. I need not tell you that it becomes a very cumbersome situation where the patient is no longer interested in the treatment or the psychotherapy or the resolution of the symptoms. In fact, the patient now is well or thinks to be well, and only wants is to gratify this enormous love that he or she feels for the therapist. And of course, that you can at times put a handle on, analyze, use constructively. A certain group of patients, unless you get in the act very early, it can grow off hand and it may be unmanageable later on, which will imply that you may well have to transfer that patient to somebody else so they will have a new start. Now, that's always a problem, because the most likely thing to happen is that after a few months they will reenact the same situation with the new analyst. And so it goes. And there are indeed some patients that somehow don't seem to be able to put some distance between the feelings that develop very quickly in this special situation of the psychotherapy. And of course, when that is the case, the prognosis for it all is rather poor, yes? So that, generally speaking, is possibly give a reasonable idea of transference. Now, there is then the problem of what is countertransference. And that's quite a problem. That's a big problem. That's more of a problem than transference was. Transference got acknowledged, got developed, people have difficulties with it, no question about it, but nothing of the nature of countertransference. Nothing of the nature of countertransference. In fact, it's a concept that was easily accepted, easily observed, easily confirmed, and people worked with it and so on. Now, at some point, Freud too, and this was not too much after he developed the concept of transference of a few years, and I will give you the quote. It's a quote from a paper that he wrote in 1910, and he said the following: "We have become aware of the countertransference, which arises in the therapist as a result of the patient's influence on his unconscious feelings," that is, the therapist's unconscious feelings. "And we are almost inclined to insist that he shall recognize this countertransference in himself and overcome it. No psychoanalyst goes further than his own complexes and internal resistances will permit." And as you see, again, this is important in this sense. That's the first description of the concept. It has an ominous ring to it, doesn't it? It's something bad. You don't want it there, yes? It's a feelings that may interfere with your ability to deal with the patient, okay? And he's calling your attention to it. Now, that was not his intention. He simply, as you see, was making a statement and giving a descriptive account of what he thought happened. Automatically, that was taken to mean, of course, that a good, decent psychotherapist should not have countertransference. If he does, he's too sick, he's too neurotic. He doesn't have a good handle on himself. And who wants to be a neurotic therapist or, you know, a bad therapist or whatever, yes? Who wants to have inappropriate feeling towards the patients and so on? So it became, for many years, this became bad news. Nobody wanted to talk. I mean, the countertransference, it was like with children. You want to know that they are there, but you don't want either to see them or to hear them, okay? And so it was treated at some distance, Of course, it is true to say, and notice this definition. It's a specific definition, yes? And it's a very restricted definition. Not restricted in the restrictive sense, connotation of the word, but in the sense that it defines a very specific piece of phenomena very clearly. And that is countertransference is a reaction that a therapist will produce, yes, on the basis of his own internal making and unconscious conflicts to the manifestations of your patient. Okay? In the transference to that therapist. It is assumed, and rightly so, and this was the point perhaps that Freud highlighted at the time, that if you react with inappropriate countertransference, several things will happen. You may well then be unable to react to your patient in a constructive manner. This feeling will be disturbing to your relationship to your patient and conceivably may well interfere with your ability to do good work with your patient. In other words, you will burden them with your own problems in one way or another. And that obviously he didn't think that it was a decidable outcome of this phenomena. Or he described too what he called blind spots. He thought that if you produce inappropriate countertransference responses to your patient, it was very likely that you will have blind spots in certain areas because you got too disturbed by these things. And again, this he didn't think was in anybody's best interest. And so, being very concerned with this, he made a number of recommendations. The first one was that any therapist, of course he was then talking of analysis, he recommended for therapists a continuous self-analysis. In other words, you should always be watching yourself and self-analyzing, particularly your responses, as provoked by your patients. And for a while, that seemed good enough to him. Obviously, being a realist and being able to observe, he came to the conclusion that though he did very well with his own self-analysis, a lot of people couldn't do that at all. And so he said that developed then the idea of training analysis for those that become analysts. And he recommended then that those that are going to use this method of treatment be analyzed themselves, and that appropriated itself the name of training analysis. And you were supposed to undergo your training analysis once. And at some point, no matter how long they were, and the length of it was very variable, at the beginning they tend to be rather short, and through the years they have become rather long. In any case, he then recommended the training analysis, and later on in his life, again, being a good observant of human behavior and a realist, he said, you know what? Really, analysts should go into analysis themselves every 5 years. It's not a matter of once in a lifetime. Really, his recommendation was do it once every 5 years. Obviously, nobody follows that recommendation. Yeah? But they do something which is not all that distant from it. Most analysts nowadays have had at least 2 analyses. That's a common phenomenon, very, very common. That most analysts, self-respecting analysts, will have had 2 rather longish analyses. It's quite a common phenomenon. It's not every 5 years, but they may well have put together 10, 15 years of analysis between 2 analyses, which is, it gives you an idea of what is involved in these things. And many of these people that has done this haven't done so because they feel particularly disturbed or perturbed or unable to fulfill their obligations, but because they have an awareness of how, their own internal life and conflictual life does interfere with their ability to be of use to other people in dealing with their own problems. And so, in order to sharpen their own instrumentation, very frequently people go into a second analysis just because they become aware that there are certain things that they don't do as well as they could if they had a better look at certain other things in themselves. Yes? So, for countertransference then, there was that restricted definition, and soon several other definitions did appear. And that's a problem with these terms, as you will see, because they become, the definition starts to grow to the point where it has no meaning anymore. And the original, very specific, descriptive phenomena that it was meant to highlight gets lost altogether. So countertransference has become several things, like Freud, as above, a reactivation of conflicts in the analyst unit, his work with patients, reactivation that may lead to an interference with the analysis and perhaps to blind spots on the side of the analyst. But, and rightly so, in a manner of speaking, some other people say that's too restrictive. It certainly highlights something that is very important and we should always have very present. But really, what you are describing is in fact the analyst's own transferences. So that in a way, it's the other side of the coin of you want to. It's a mirror image of your patient transference to you, just like the patients, yes, which after all are human beings, just as therapists are, have this ability to transfer or to displace onto other objects, specific objects, feelings from the remote past without being aware of it. So do therapists and analysts. And it may well be that for a variety of reasons they will transfer this to their own patients. And so the countertransference became the analyst transference, in which particular case the object of the transference was his patient. And that's a way of defining it. It's a very wide way of defining it. Some people saw that it's difficult to argue against that. There's no question that therapists are human beings and they will develop transference to all kind of other people as well. And conceivably, in such a situation that gets us intimate and hot as an analysis or an intensive psychotherapy will get, these things are very likely to happen to some measure, given that we are all human beings and nobody is perfect. So, in a way, one cannot argue with it, but as you see, it becomes so general that then it's useful in the descriptive sense, but what do you go next with it, or what practical value does it have beyond the descriptive one? Some other people then started to say that if you use it in this sense, that the patient becomes like a present-day substitute for an object of the therapist's infancy, which will be the transference of the therapist, then it's too general. What else do you do with it? So other people say, well, let's define it differently. And they say the whole of the conscious and unconscious attitude to his patients, which may or may not lead to difficulties in the therapy. That was Balling's definition, for example. Or other people like Gittelson in this country preferred to use a term with a specific limitation, and that is limitations on the psychoanalyst brought out by particular patients. In other words, that he restricted it to special circumstances where certain patients with certain type of problem provoke certain types of reactions in the therapist. Or other people has talked of the appropriate or normal emotional response of the therapist to his patient. And this is then an important tool, the countertransference, and a tool that can be used to understand and to be empathic to the patient. But for many years then the countertransference was bad news. It meant that you have troubles, and it really meant that you should go back into some form of treatment, or somehow you were not good enough or suitable enough, and nobody wanted to identify himself or herself in this particular light. So it became a conspiracy, the countertransference, for very many years. And suddenly it came out of the closet, so to say, and made an impact. I think the man who managed to do that essentially was, I believe that, I may be wrong about it, I think it was a man by the name of Winnicott that you are familiar with. Winnicott, I was saying yesterday in a different group, was an extraordinary man. He was a genius, though not a stable genius. Didn't have the stability of Freud in the sense that he was constantly at a high level of performance. Winnicott was a different type of genius. He oscillated, and I told you this, I think, possibly some other time. When he was good, he was very good. When he was bad, he was very bad, like most human beings. And so when he was very good, he was the best diplomat in the world. I wish he were alive and we could send him now to the Middle East, to Lebanon. He will solve the problem, no doubt about it. So he said, this is a problem. And he wrote a paper. You know what he called it? And it was in the 50s when this was an incredible taboo. He called it Hate in the Countertransference. And he published it. Only Winnicott would have done that. You would have needed his courage and his talent. And apparently these are two rare qualities. In any case, he did publish that particular paper. And I tell you how he did it. He did it in a way that did not provoke anybody, save face. He did what the Chinese recommend. Never get an adversary in a corner. Give him a way out of the corner. You put it in a corner, he has no alternative but to go against you real quick and real badly, yes? So give him a way out. In other words, throw him a towel. Or let him save face. The Chinese will say, don't make anybody lose face. He can live with that. You make an enemy. Let him save face. That's what Winnicott did for analysts. He let them save face. How? In the paper he said, well, of course, these observations that I'm going to refer to were made in a psychiatric ward for psychotic patients. You see his skill, long left hand, yeah? People could say, well, yeah, in that area, yeah, I could see that there, yeah, sure. And so they did. He did more, though. He sort of gave you that introduction, sort of, if you know Winnicott, I am a great admirer of him, and still am. He's dead, but I thought he was the greatest teacher I ever had, or one of the greatest teachers I ever had. So then he added the other element to make it more palatable and lead you where he wanted you to be. He wanted you to reason, and to reason without fear, and to be able to face things that were very difficult to face for other people. And Winnicott had that personal skill himself. Remarkable skill, admirable skill. So what did he say? He said, look, mothers love the babies very, very much, but they hate them too. Very, very much. So it is not all that unreasonable that therapists love the patients, in inverted commas. You don't have to, but that was the myth. You know, if you are in this business, you are a great lover of all patients, yes? And you don't have bad feelings for them, or should not, because that was bad. Well, Winnicott said, not so. Mothers love, and mothers, that's the greatest love there ever was, yes? They love the children, but they hate them too. And they hate them with a passion, just as they love him with a passion. And he gave a list of about 50 or 20 reasons to you why mothers had every right to hate the babies. And if you read them, as you read them, you say, you know, he's right. I mean, you wonder why it is that they like the babies at all. They should kill all of them, hate them. Well, you see, he was making these things palatable. Things that were very difficult to handle, had become a taboo, grown out of hand. He turned it around and told you, look, go into a psychiatric ward, and you will see how people will react to these patients' manifestations after they have been there for some time, the staff, how some of these psychiatrists and the staff looking after them become very angry with them and very hostile and will be cruel. You only have to go and observe, and you will see how they get restricted and what they do and how they get into isolation rooms and get manacled, and, you know, now we think a little nicer. We restrict them chemically, which apparently is a little better, yes? But we do the same, okay? And I'm not saying, don't take me wrong, yes, that this is not necessary, and that at times this is not the only thing and the only good thing to do for the sake of the patient and the sake of those around the patient. It is. That's not what is in question. What is in question is the sadism with which this may be done by some people, and the fact that it may be done more than is necessary, frequently, just to gratify tendencies of other type in other people, yes? And then he said, so that make it palatable. People say, yeah, I can see that there. Sure, well, yes, I have seen that. And then when he said to you, look, your mother loves you and hate you too, he sort of gave you a reason to say, well, then I am entitled to love and hate the people that I see too, and those that I relate to. And I thought he broke the ice, yes? And then the concept of the countertransference took off in a real big way. In a real big way. And the countertransference, that was a bad thing to happen to any therapist, became for some people a very useful tool that you can use very constructively. In other words, you can observe your own countertransference, and it can tell you very meaningful things about your patient, though these are your own feelings. And a whole set of arguments develop. What kind of use do you make of your countertransference? Do you tell your patients what they make you feel? There are therapists that say, yeah, go ahead and tell them. They piss you off, tell them. You piss me off. I don't recommend that, but there are people that does. There are therapists that said, no, don't use it that way. That's not necessary. And certainly don't burden your patients with your own problems. If you reactivate your own problems, yes, and he's talking about his dead mother and how sad he is, don't start crying because it reminds you when you lost your son or your wife or whatever, you know. He's not interested in that. Well, he doesn't need your burden. He has his own. So don't pass yours to him, some people will say. That's not appropriate. And I tend to be inclined to agree with that. They don't need your problems. They need to deal with the problems, and you should do nothing that will sort of handicap the resolution of the problems. Or situations which sometimes you read, they are quite interesting, you know, where you wonder who is being the patient of whom and who should be paying whom for the session in that particular occasion, because, you know, the roles get reversed in a bad way. Not that you are not a human being. Not that you will not be moved by things that patients do say, and very much so. Not that you should not notice these things, but then, and this is the school that I will tend to subscribe to, you should observe that, make a kind of distillate of it, purify that compound, and get those elements of it that you can feed back to the patient and in a constructive manner, and he can use for his own constructive insights. And it doesn't contain anything that belongs to you and should not contaminate your patient. And if you can do that, that's fine. I have no objection to it. So, but there are people who have, of course, recommended all kind of ways of dealing with this. Now, let me tell you a little bit about transference and acting out. How I'm doing for time? I have 10 minutes? Not because I want to, but because the two concepts are very closely related. You see, at the beginning, when transference, again, and we are talking of the beginning of the century practically now, It seems incredible, but that was the nature of the genius that describes this phenomena. It was 80 years ago. Seems very simple today, very easy today to talk about these things. You say, transference. Well, it is not that easy, not even today. We're still arguing about what this phenomena is and where it comes from and how do you handle it and what does it mean, and people is not in total agreement about it, and it seems to me that that's the right way to describe the state of affairs, because it's a very different, very complex phenomena that has enormous implications and weaves itself in all kind of other problems and areas. And the same is true of the countertransference. Well, originally, you see, these forms of psychotherapeutic treatment, the original assumption, which is correct, was that it was much better if the patient could remember things during the course of the sessions. Now, Freud soon became aware that that was really, though he knew that that was preferable, that was not always possible. In fact, it was not what actually did happen, that there were patients that were not capable of remembering and telling you in words what had happened or what they were feeling in a contained manner that could describe to you the memories and recover them. He wanted people to remember and to verbalize these memories, and that's ideal. Still is ideal. As I say, he noticed that that was not possible for many reasons. Many reasons. One of them is that many of these things do happen before language is properly developed, and there is no language to describe them at all. So he said, well, some patients are unable to remember. And so what they do is to reenact them in the context of the transference. In other words, they act them out in the transference. And that's the original definition of acting out. It was the alternative to remembering in the transference. Instead of remembering and verbalizing your memories, you acted them out. You felt them. You got angry, for example, and you couldn't say to your analyst, I am mad with you like you haven't seen. I could kill you. What you will do is you wouldn't come to the next session. You acted it out in the transference, or something of that nature, yes? And he was very cognizant of it. Yet, again, historically, when the concept first appeared, it looked that acting out was a second-class citizen. And that in a way it was not as good as remembering. It's like with anything like this, remembering got somewhat idealized, and acting out became a little, had not a nice connotation. And from there, it very quickly became something very different. Acting out today is very difficult to define. I couldn't define it to you today. I mean, when I hear the ways it is used, I will say that anything is acting out, the way it is described at times or defined at times. And obviously, once you are in that situation, it's not too good. It doesn't help you to describe anything or to define anything or to put limits on anything. Now, acting out quickly then became something that happens outside the transference. It's a bad term, okay? It says out. And people assume out of the room, yes? Out of the transference, out of the therapeutic relationship, out there with other people, outside the psychotherapeutic hours, outside of the psychotherapeutic relationship. And that's the meaning that it acquires. And of course, there are innumerable impulsive characters that act out. And that has today an ominous connotation. You know that actors out have poor prognosis. If that cannot be controlled in some manner or another, you don't know what will become of these patients. And of course, acting out has the potential to do an enormous amount of harm to the patient and to others, because the patients retranslate into motor action and behaviors, yes, their conflicts. And this retranslation sometimes can have incredible results. It can be violent acts, destructive acts for themselves, for other people, for society. And of course, once these things have happened, what do you do? I mean, when you say, oh, that was a piece of acting out, you know, some of these pieces of acting out are not retrievable. The damage is there for good, for life, so to say. Well, obviously, people being clever, they say, well, that less than is, and this is the historical imperative of the development of concepts. Acting out became something, not the alternative to remembering within the transference, yes, showing you, therapists, what you feel in your behavior, but without ever going too far into motor action and without ever, yes, making a violation of the original contract, and that is that you will not behave. You can say what you feel, yes, and you can even, but you won't, if you are angry, you are not going to hit your therapist. That's a no-no, for example, yes. That's translating behavior into motor action, that you will continue to come to your sessions, that you will continue to free associate and things of that kind. That you, and within those limits, within the respect to these different parameters, you could then reenact some of your feelings and perhaps not come to your session and so on, which if you did forever is no good, obviously, you know, it's not going to do any good to anybody in that particular way. Within limits, reenacting, acting out in the transference was a substitute for remembering a good one, the only one that a lot of patients can produce in relation to certain type of materials, the only one that in fact is possible in many analyses for certain specific areas of conflicts. For others, a patient can remember and tell you any number of things. For certain things, he can only reenact them from you, show you in their behavior what they feel or why they feel that. So somebody came and said, well, we already enlarged the concept and now we are in trouble because we have two very opposite means to acting out. One is an alternative to remember within the transference, the other is behavior outside the transference and outside the office. So let's call that happened inside the office and the transference acting in, and the other one acting out, okay? And that's a common way of describing the phenomena today. I don't much care what you call what, as long as you know what you mean, and as long as it helps you to make certain distinctions, and it helps you to understand that patients that acting out is not as ominous in connotation as it is implied by present-day definition, where indeed, if that is a phenomenon that it covers, it means very poor prognosis for a patient. Patients can act out in certain forms, and these forms of acting out are not malignant forms of acting out, are part of the psychotherapeutic situation, and are the only way of communication that the patient may have available to him or to her in this particular conflictual area. So, we got to say just 2 or 3 words about children and adolescents. And I'm sorry I have to hurry you through these things, but that's the nature of time. Yes, it never stops to let you do what you want. In any case, this again is an old issue. It's a very debated issue. It's not necessarily true to say that there is an absolute consensus on what people will think at what is the transference in children or adolescents like, and I will describe in the same phenomena or not. In a very brief sketch with children, nobody argues that adolescents produce transferences, and quite intense and devastating and tormentuous and explosive and stormy transference. In fact, you take that for granted. That's what is going to happen. Just as you take for granted that these transferences have little stability and move very, very rapidly from 1 minute to the next, from one position to the next, so that now he's like a small infant sucking his thumb and he was a teeth in his mouth and you must give it to him. And you do that, and by the next 5 minutes, he's saying, who do you think you are, treating me like an infant? I am a man. I just fucked a lady last evening. You don't know that, you bastard. And so it goes, you see. He's an adult, and a rebellious adult. And the transference oscillate in a very violent manner. And it is there, and it's there from the beginning. They are like adults, really. Only that given the developmental stage, it acquires certain very specific characteristics, because what they feel it with a passion. It's a stage where the ego, yes, vis-a-vis the drive and the balance between the two of them, loses some of the ability to modulate these impulses. And they come with such an impact suddenly on them, with such a force that they don't know what to do with it. So they get acted out in all kinds of ways. Adolescents are the greater actors out. I mean, if you think that you can contain an adolescence in the transference, remembering things, you have a big surprise coming. It's not going to happen. You are not going to keep him in treatment for very long because he's totally incapable of doing that. For the most part, if you are lucky and you know what you are doing, you will get that part of the time and be very happy when you get it. And the rest of the time you try to put a handle on whatever else he's going to bring to you, which is not going to be too good much of the time, yes? And so it goes, you see. It's not that he cannot produce transference, he does. And they are of such a violence that sometimes he has to run away from it to protect you from his feelings and to protect himself from his feelings. Now, usually an adult has passed that stage. He can have very violent feelings, but he's a little more stable and more settled in his ability to control this, to put a handle on them, not to be overwhelmed by it. And so it goes. You know, there are these differences. With children, though, it was different, you see. People, and there is still differences of opinion. Originally, some people thought that children were not quite capable of developing transferences, and that included people like Anna Freud. And if you read some of his early publications, that's essentially what she will say. That at least in order for children to be able to develop a transference phenomena, somewhat equivalent, not identical, but somewhat equivalent to that of an adult patient, it requires a period of preparation. And if you read some of the earlier books on technique that she wrote, that preparation period, which could take anywhere up to several months before the child was ready to enter treatment, was a fixture of the treatment of children. And it was not assumed in those days that until you did that preparatory work, the child was ready to come into treatment and as such to be able to transfer some of these feelings to you. Now, he abandoned that view, and certainly when I was in contact with her, she didn't think that any longer. But she, you see, much of what people assumed that she meant to say was not what she actually meant to say, though what she wrote, in a way, suggests that and could be interpreted in that particular way. What she meant to say was not that children were not capable of developing transference, but that the transference were very, very different. They had special qualities and characteristics of their own, and that the main reason for that was very simple. The children were experiencing those needs as contemporary events in the here and now. Okay? And not only were they, in other words, these were needs not from the long past that I experienced in relation to my parents. I am feeling them right here and now in relation to these parents. You see what I mean? It's happening to me when I am a year old and 2 years old and 2.5 years old. I'm not bringing them back when I am 40 from my, second year of life to my therapist. That's a different issue altogether, okay? And she said too, which is certainly true, that the other problem that makes the transference of children quite troublesome and different, not that they cannot produce transference, in fact, they produce immediate transference. Immediate. If they settle with you, they have the same expectations of you that they have with their own parents. Immediately, automatically. And will expect, in fact, they are surprised if you don't do that. The moment they get a little, they don't do, a normal child will not do that just the first time that he meets with you. He'll be very suspicious of you, and he should be. But once he knows you and accepts you, he will make an immediate transference. There is a difference, though, and it is a very important difference. It's imagos. These are not imagos. They are real objects. They are there, and the moment he leaves the room, he goes back to mom, who takes him in his lap and cuddles him and kisses him and touches him and erotizes him and feeds him and does all kinds of things with him, which she should be doing with him. So you tell me, what does he need you for then? Why is he going to, I mean, with you as an adult, you are longing for something that is long gone and you have no right to it anymore. But he's doing something to which he's entitled developmentally, and everybody is quite willing to please him with his needs. Why? You think he's a fool? Only adults behave foolishly. Children never do at that age. They know a good thing when they have it. So they are not about to change it for somebody else that is there for a little while and is not willing to go as far as mom is going to go or dad is going to go all of the time. So as long as they are with you, if you know how to treat them, they will make an immediate transfer and you will use it. Yes? Very, very similar. In fact, I will say quasi-identical with what you do with an adult. But the moment that child leaves, you lost it. He's back home with his real infantile imagos. He's gratifying these needs. He's entitled to it. It is due to him, and so that it will be. And there are this enormous difference between the transference of children and adults. One final word about the transference. You see, we have been talking about this transference in inverted commas. It's a special phenomenon. And we said, or I said a moment ago, that obviously the whole idea of object relationships, in a way, is based on this idea of the transference, yes? Whether we were aware that that was the way the ball started rolling or not, it really did start rolling at that particular point, in that particular direction. But there is a whole issue of the real relationship to other people. You see, transference is only one aspect of human relations, and a very specific one, very well defined and restricted to certain specific things. When you relate to another human being, you bring to that relationship, hopefully, if you are a reasonably normal person and not too overwhelmed by your neurotic conflicts, you will bring your logic, your rationality, your ego reality of what this person is, means, what you have to do with them, why do you relate to whom as a rational adult, neutralized, non-neurotic, non-necessarily gratifying of primitive needs, relationships. Okay? And that's the way it should be. And that's the way indeed it is in many cases for people that are capable of functioning at a reasonably normal level. But even such people, of course, had early experiences and had, no matter how normal they are, certain longings left behind, certain needs that are now gone, but it was nice to gratify when that was possible and acceptable. And it is quite possible, too, that then what you get in most human relationships is a combination between these two set of factors. The displacement of these infantile imagos to the relationship, which then make this person into something that it is not, but an image from the past, an object from the past, in whom any number of longings and expectations are placed. And if this person doesn't gratify this need, the reaction will be what would have been appropriate at 2 years of age, which means the elements of the reality, of the distant, neutral, logical, rational ego, yes, that acknowledge the basis of this relationship to this object human, this other human being, this other object, would have been lost. And then it becomes really a neurotic interaction, yes, where one of the parties is constantly surprised and the other one is constantly disappointed. The disappointed one is the neurotic transferer, and the one that is constantly surprised is the recipient of the transfer, because they say, but what does he want? What is it? What is this? And I'm sure you all have been in this position, especially those of you that have ever occupied any position of responsibility anyway, because that automatically makes you into some kind of authority figure, father figure, mother figure, parents figure, both mother and father, and you get all hell loose if you are not careful with people that have the need, yes, because of the neurotic, non-resolved problems and attachment to this imago to bring them into the relationship to you. And I wish you well if you have too many of these, because they can drive you off the wall, yeah, in a real relationship. So, it is important to be aware of this. Everywhere, this interactional, object-relational phenomena has more to it than just what we have described as transference. That's an important element of all human relationships, Most human beings, if not overwhelmed by the nature of the conflict, or regress, or enormously frustrated in external reality that force them into a regressive past and longing for the earlier, more gratifying imagos, will be able to put some distance and not to let too much of this inappropriate demands filter into the reality of the relationship. The ego will say, you know, it'd be nice if he behaved like my father, but he's just my chairman. You see what I mean? Or if he's just my boss, or he's just the administrator of the place, or he's just the president of the United States. He's not your father and cannot behave like your father. You see what I mean? And most people are in a position to do that much of the time, most of the time, really. Those people that are overwhelmed by the nature of the conflicts, that are enormously fixated to this stage, and could never transfer these instinctual forces, these cathexis, into the world of realities and the objects of reality in a neutralized manner that then allows you to interact with people at an adult neutralized level, of course bringing to the relationship the neurotic transference. And they are difficult to deal with, and they are frequently very disappointed because it's practically impossible to gratify the needs the way they experience the needs. You have no idea of what it is that they want from you, really. So there are these two components. We, in treatment, make use of both. And though the transference is a terrific instrument, that aspect of the relationship, which is the real relationship, neutralized, is enormously important. And just to round it, transference interpretations are enormously important. They are not the only type of transference that is possible during treatment. There are people, schools of thought, that will put everything inside the transference. It doesn't matter what it is, they will retranslate that in terms of the transference relationship, and whether that is even appropriate or not is frequently quite questionable. But there are people who really believe that the only way to be effective is to retranslate all of this into the possible language, symbolic language of the transference, and give the interpretation at that particular level. And there are people who will say, don't do that. That's neither necessary, nor rational, nor appropriate, nor representative of the needs of the patient and what is happening to the patient at the particular time. And you combine, you give to Caesar what belongs to Caesar, yes? And to whoever else is there, what belongs to whoever else is there. So you treat the relationship in that particular way. And what is transference, you deal with in the transference. And what is not transference, you deal with it in the actual real relationship. Now, I told you, there are people who will not want to develop any kind of transference, either positive or negative, and they will bring all of it in terms of a real relationship or relationship to people outside. And these, of course, are special forms of resistance to the transference, and you will have to handle that. But it's impossible to cover all the possible eventualities of this. I just want to give you a little sketch of it. Thank you much.